Hello and welcome. Hello and welcome to all who have joined us for this session from different parts of the globe to World Catholicism Week, organized by the Center for World Catholicism and Intercultural Theology. And so I'm Sister Teresa Kiragu, an Assumption Sister of Nairobi, and a PhD candidate in moral theology from the Catholic University of Eastern Africa, Nairobi, Kenya, where I'm also an adjunct lecturer. And I was privileged to be a Summer Junior Research Fellow in 2019 at the Center for World Catholicism and Intercultural Theology at DePaul University. So I'm joining you from Nairobi, Kenya, and I'm delighted to be part of this conference and the chance to moderate this session, since also my PhD is focusing on holistic healthcare and culture of life in Catholic hospitals in Africa. Hope to get insight to enrich my dissertation too. So to all of you, welcome. So to all of you, you are most welcome. I wish to share with you a couple of brief comments, if you like, ground rule. So each of the presenters will have 25 minutes to present their material. And after that, we'll have the Q&A. And so while you are listening and processing, and as you are letting your presentation weave together, write down your question, either addressed to Susan Nedza or Samuel Orach, or to both presenters, and post it on the Q&A. And after the three presenters finish their presentation, we have the two presenters respond to your questions. So we are glad to have three wonderful presenters. Two presenters of the session have joined us here already. We have Susan Nedza and Samuel Orach, while Soojung Kim could not make to join us. We will listen to the video of her presentation instead. So our topic of discussion for our session is Catholic healthcare services and strategies. So it's my great honor and privilege to introduce to you our first presenter, and I will read through her bio. Our first presenter will be Susan Nedza. Susan Netzer is an emergency physician and a healthcare executive who has participated and led in volunteer organization in Latin America. She is currently the president of Olancho Aid Foundation, a Catholic project that focuses on education, health, and clean water project in Olancho, Honduras. Dr. Nedza also serves as an adjunct assistant professor at Northwestern University Feinberg School of Medicine. She is a board certified in emergency medicine and clinical informatics, and her past experience includes serving as a chief medical officer for Region 5 at the Center for Medicare and Medicaid Services, and as a senior executive at the American Association. She received her bachelor in chemistry from Ganon University and her medical degree from Loyola School of Medicine. She completed the executive master's program at Northwestern College Graduate School of Management and hold a Master of Liberal Arts from the University of Chicago. Her most recent studies have been focused on the utility of using eco-poetry to encourage activism in addressing climate change. So we are delighted to have you, and I invite you to join me in welcoming Susan Nedza. She is presenting on accompaniment as the Catholic Medical Mission model, responding to the call, go forth. So you are most welcome, Susan.
Good. Thank you, Sister Teresa. And I think you need to sign off from screen sharing so I can start. Oh, there it is. Thank you. All set. So thank you, Sister Teresa, for the kind introduction, and to everyone at CWCIT at DePaul. It's a pleasure to be with all of you this morning, and to the members who are joining us. I'm really excited about the chance to share some information about the journey we've made in trying to improve medical mission models in Central America. So every year, thousands of Catholics of all ages set out across the globe to provide healthcare to others. There's no actual count of these individuals, of the organizations they join. They make trips such as spring break, solidarity trips. They join medical brigades. They do alternative spring breaks from college and other models as well. They often travel alone, sometimes as families, with groups from parishes, hospitals, or a group of specialists providing care specific to their specialty. Honduras is often a destination. In many cases, they're all strangers seeking the same experience. They have at least one thing in common, though. They really have a desire to help as individuals and in teams, and they believe that they can relieve suffering through the provision of US-type medicine. Unfortunately, these trips are often short-term. They're sponsored by global volunteer travel companies. They target college students, affluent families, focus on the volunteer experience. They're sold as an opportunity to gain pre-professional credentials or practice skills. They're not yet licensed to provide in the US. They are often ill-prepared for the trip, where most of the preparation has been about vaccinations or packing lists, and they're unlikely to be coordinated with the church. My goal this morning is to show how a series of documents penned by Jorge Bergoglio, Pope Francis, how we were able to use these as a Catholic organization to embrace a very different model of medical mission work, one of accompaniment. In this limited time, I'm going to provide a summary of that conversion that has taken a number of years as well as is ongoing and very difficult at times to stay committed to. A deeper explanation of this transformation will be found in the proceedings for the conference. So I'm a volunteer. I've worked in a number of different countries in a number of different areas, both urban and rural, multiple different kinds of missions, both Catholic and secular. And my own personal experience has really guided some of the work that I've been engaged in Honduras. And I'd like to start by telling a story about one trip to Guatemala. I was with a very large medical mission team. They'd been going for a number of years. We had half a hospital that we had worked with the hospital to use. We did multiple clinics, many surgeries within 1 week. And one night at dinner, a group of resident physicians who were there to provide services with us were marveling at their ability and ingenuity to treat women with the very, very common complaint of neck pain. The treatment that they were prescribing included stretching exercises. They gave them a 2-week supply of nonsteroidal anti-inflammatory drugs like Motrin, and provided a tube sock that had been filled with beans that could be heated and used for pain relief. The conversation made me think back to my experience earlier in the day when I was giving discharge instructions to a woman. When asked by a volunteer interpreter if she had any questions, she shook her head and said no. Yet then she turned to me and shyly asked in Spanish, "When socks and food are in short supply, why would they suggest this?" She went on to ask if she could have a second bean bag so she could have a complete pair of socks for her son and more beans to cook. The lesson regarding our misguided effort became even more direct when we were driving out of the city. We saw women trudging down a dusty road burdened with water jugs on their heads. Yes, like Paul on the road to Damascus, I had been struck down, and it was only when blind resolved that the truth revealed the treatment for their neck pain was not nonsteroidal anti-inflammatory drugs, but access to clean water. And this is a picture of a postcard, actually, that I found. This is the hospital in Jalapa, Guatemala. And you see the American tourists not really dressed for where they should be, taking photos of these women. And it really did strike me as this is an interesting way to look at this, especially with the church in the background. So I think I really do need to start by saying something about the role of the church in Latin America, and it's different in various countries. There isn't a lot written about Honduras. There are some books and there are some scholarly articles, but it's somewhat of a different experience than that we've seen in Africa, for instance. Honduras itself has been, gained independence in 1819 from Spain, the church was associated with the colonial Spanish model. So they're 200 years post-colonial models. Unfortunately, they were then colonized by US businesses, henceforth the term Banana Republic, which came to be known about Honduras. And so most of there was a barrier between the church and the rural communities. Their dealings were more with the owners of these very large plantations than they were specifically with the government. There have been issues related to the Constitution over the years, which has been amended most times. Their religious schools initially were not allowed to teach religion in schools. That's changed a bit. There was also a significant shortage of priests in the country. Even in the year 2000, there were just over 300, and 80% of those priests were associated with religious orders. The other thing that happened was that there was a great fallout from the church's foray into adopting tenets of liberation theology by seeking land rights for the indigenous. So for instance, in the area where we work, in 1975, 2 priests were murdered, along with a number of others, including some rural individuals, and dumped in a well. You don't hear much about it. We hear a lot more about what happened in El Salvador or Nicaragua, but the same has gone on in Honduras as well. And there was a period of time, even up until 1983, where the church was not very active. Why this is important for healthcare is it really has limited any kind of development of a church-based healthcare system. This is a picture from 1971 of Padre Lupo Carne, who was a Jesuit missionary who also worked with the campesinos and actually disappeared in 1983 and was later the government admitted that he had been killed. And that was this was a picture of a group that is using mules to carry supplies up into the mountains. And this was kind of the norm up until the mid 80s. So I work in, as I mentioned, in rural Honduras, where we're working to try to help families stay healthy, stay together, and have an option to stay at home in Honduras. Most people really aren't even aware of where it is on the map, partially because it hasn't really been in the news until recently because of hurricanes and other climate disasters, but more recently because of the issues of migration into the United States. And part of the efforts that we're engaged in are trying to help with the church to create activities and activities that help people to stay home, which includes job development and health system strengthening. So I want to give you a little bit of history first about medical brigades. And this is a fact that this is really an industry. There are, in 2008, a web-based search identified 543 independent faith-based trips and estimated this generated $250 million in expenditures. A Canadian study indicated that in 2011 that they thought there were $19.3 billion spent on medical mission work. In Canada, there is a much more vigorous and rigorous data collection, and they're associated with other churches. But in the Catholic world, there is no one source for information on these types of trips. I did do a recent search trying to see if there was any additional information. And what I'm sharing with you here is that, yes, there are dioceses involved, there are Catholic foundations, there are others, small groups, large groups, some associated with a parish. There are medical brigades, and brigade, of course, you can imagine is not a great word to use when we're talking about trying to accompany anyone, that are associated and affiliated with universities. I found that there were approximately 16 different Catholic universities who have these chartered groups within that are usually student chartered and really aren't affiliated with the university. So activities are going on, people are going on trips. However, they're not necessarily engaging in the kind of care that is actually going to make a difference. Many of these it's been studied, and they're based on a colonial or savior model. They're disconnected from the local healthcare system. They're uninformed by actual community needs. They lack measurement of any outcomes for the community and participants, and they depend on individual donations by those participating. That is indeed the case for the college models that I illustrated here. And, again, you can see the focus is on the volunteer and not those that they're trying to improve the life for. They have this dream and they write a blog post, and most of the literature that's out there is personal recollections of the difference they made, and more importantly, how the trip impacted them. There's other literature to show that it doesn't hold, that within 6 weeks to 6 months to a year, there's very little left in their lifestyle or their charitable actions that really reflects what they saw in these other countries. If anyone would like additional details about some of the research, I did a more extensive literature search for the conference, Faith in Action, that was held in Africa and Nigeria in 2019. So I would refer you to that book, which is available through DePaul. I think the most important message that I received and really confirmed my thoughts after leaving the work in Guatemala was that this is a quote from someone that's very familiar with medical missions, and that they really do not, good intentions aren't enough by those who plan, support, or participate in them. There's been even more criticism of these models, including information about the harm that they can do in a community, where people will wait until they will wait to be seen. They will delay care. They will have medications that they're given that they don't know how to use appropriately, or they have no follow-up care. And so harm can also be associated with these trips. So I began working in Honduras in 2015 and inherited as part of the board and the leadership of the organization, this kind of medical mission model. And people said, well, you're a physician, you've done this work, what should we do to change it? And there were those that saw nothing wrong with it, and there were those that wanted to expand it. They thought this was a great way to bring more people into our donor base, to be very honest. So we started by looking at best practices, and I have to admit, I put the long road from Quito into this presentation before I knew that Dr. Goss was going to be participating. But certainly Partners in Health is held up as a great example, as well as the type of information that really does identify the long-term commitment, as well as the need for health system strengthening, that really did identify the fact that our model was indeed problematic. It traditionally was a 1-week trip. We distributed 2 weeks of medications. We gave antiparasitics to children who continued to get reinfected. Again, people practiced beyond their license. There was no connection to the public or private healthcare sector. And part of what we did was distribute obsolete equipment to some of these, the folks that we were trying to serve. So what were we to do? We're a lay-led organization, and there are a lot of lay-led organizations historically in Honduras, both through the church and around it and in other faith traditions. And I had, having read Paul Farmer, learned about, Father Gutierrez and liberation theology, and started down a path of looking for outside information to help support us. And henceforth, the decision to pick the Aparecida document, Evangelii Gaudium, and then Laudato Si. Certainly we looked at other documents like the Puebla document and the discussion at Medellin, but these particular documents, I will say books, were more contemporary to the work that we were trying to do. And we knew they'd had at least the Aparecida document had a significant impact on the church in Latin America. So we had a number of questions we needed to ask. The first was there a role for us, led by laity, to address healthcare needs? For the purpose of this conversation, I'm going to go through some of the work that we did thinking about this and discerning and making decisions rather rapidly. The paper will have more information about that. So the preferential option for the poor is one of the distinguished features of the Latin American and Caribbean church. The passages we chose were examined in the context of our embrace of this preferential option in all of the work we do as an organization, with a special role on the focus of laity, the role of parishes, responsibility of Catholic institutions for higher learning. We did discuss and discern about the role that lay men and women would need to play within the organization as missionary disciples, and the kind of opportunities we provide for individuals to do that through, they come from generally the United States, from other countries as well. We also thought about how we could support and utilize the work we were doing through rural parishes. And the Aparecida document specifically speaks to rural parishes. And we wanted to make sure that whatever we were doing was in communion and also was really linked to what the parishes were doing, because these parishes exist in the rural community. They're often led by laity, with priests visiting, on a rotating basis for Mass and for the sacraments. And so our connection to the rural communities made sense as well. And finally, we did have a long conversation about Catholic universities. We attract volunteers, long-term volunteers who've attended Catholic universities through the Catholic Volunteer Network, but we really not connected specifically with those universities and the students, and participating and providing an opportunity for the students at the Catholic universities to have a chance to visit and do especially those in the healthcare sciences and social sciences. But at the same time, what could we do to help Catholic universities forward their mission as well? So our conclusion was that we could serve as this organization, lay-led, closely aligned with the parishes in the community. We have a strong relationship with the bishop who over the area of Juticalpa, who helps to guide us, as well as outside theologians and others who will provide information, as well as support and help us with our discernment of our work and help to direct it. And we are seeking to expand efforts with Catholic universities specifically, to help them fulfill their university mission. With regards to the joy of the gospel, Evangelii Gaudium, the question we asked was, how do we ensure that a missionary discipleship of the individuals who participate is about those we seek to accompany? I've already spoken about and mentioned, the focus on the volunteer and their experience in a 1 week or a 2 week short period for someone who doesn't speak the language, who really is maybe ill-prepared to participate, and to help them understand the importance of accompanying the individuals that we're serving. And what struck us was first Luke 24, verse 29, "Stay with us, for it is towards evening, and the day is now far spent." As an American NGO, and as Americans, we tend to think things will happen quickly. The 2 week supply of a leave that I mentioned, or Motrin, along with a bag of beans and stretching exercises, will make a big difference in someone's life. That's how we practice medicine in this country, is very disease-based, as opposed to being based on health. And so the idea was that we had to recognize that it's important to spend time, and it would take time, and we needed to be patient. So although we really cannot look at ourselves as heroic individuals, humility is key to any of the work that we do. And as we educate those who come to work with us, that this needs to be at the core of the mission. And to realize that we're learning from these individuals. There's also a emphasis on teaching skills like brushing your teeth and others, but there's so much that we have learned over time about issues like access to water, how the healthcare system works, and just the difficulties that they know through the suffering Christ, because many of us have not had that encounter in our lives. We've been blessed with economic prosperity and have not faced the same type of struggles that these individuals have, and that they can help us to learn from. And we needed to stay by their side. There was no way we could do this alone, and we had to integrate in with the community that was going to continue to care for them. There is a Catholic hospital in the area that we will continue to try to seek out and to partner with as part of our mission going forward. And we don't want to take time talking about what needs to be done. This is habría que ismo. which is basically being the spiritual masters and pastoral experts who give instructions from on high. The history of the United States and Honduras is not a good history, both from an economic imperialism position, as well as a, the support of the military, the coups, any number of other things, and that, are well beyond the scope of our discussion today, but all have an impact of the view that individuals in the community have, and the distrust they have of Americans in general. So we really needed to become, we didn't want to become this pitiful NGO that the Pope has referred to, focused on plans and projects, and not really keeping Christ at the center of what we've done. We've really rededicated ourselves to that, and to learn from the people that are teaching us through their suffering, that we are not being heroic and serving them, but we are acting as the Lord's hands. Most recently, we, as a board, actually did some study of Laudato Si, as people were beginning to ask us to become more active in the climate area, but more importantly in the health of the environment, as we saw that health was so dependent on clean water and climate change being controlled and other things. So the question came, do we expand our focus on health, not by providing healthcare, but moving into other areas that were related to the health of the community? And this is again, a flashback to the story that I told at the beginning. It's hard to have adequate ways of solving these complex problems, and they're not going to be technical. We've learned that a single perspective is not going to do it. And really that the idea that solely the curative model of the United States is going to be enough in this community. It needs to be a both, not an either or, but we need to begin where we need to begin. So we started to develop a holistic plan and it's being done in cooperation with the community, the diocese, and within the context of the health of the environment. This includes heavy metal poisoning in children from mining, debris that is washed down through the rivers, agricultural chemicals that are now polluting the water source, and other areas where we need to be able to work. And it all came back when we really did start to look full circle. We really shouldn't focus on high cholesterol and high blood sugars. We can connect people to others in the community, to the government resources. We can help strengthen those resources. We can help strengthen the ability of physicians that are there 24 hours and healthcare workers, community healthcare workers, to manage things like diabetes, yes, but that's not the direct work we need to do. We need to work and focus on the needs of the community, which has led us into doing more work related to the provision of clean water. And we had to start from the ground up. The photo you see here of the volunteers crossing the bridge, I happened to be in the Jeep with some of the individuals who were helping us with the trip. And I found it, it just serves as a picture of, the volunteers didn't know where they were going or what they were going to do. They were just putting their faith in us that what they were going to do was going to make a difference. But in fact, they shouldn't have been asking the leaders who were already across the bridge. We should have been asking the people who were in the river and watching us what we were doing. So we're working to build from the ground up. We continue to build bridges with Catholic parishes to help to educate about these models. I'm continuing with my research in the area and the diocese to ensure we're doing what the community needs, and that we can help them stay healthy, stay together, and then have an option to stay at home in Honduras. The end of the story is yet to be written. As I hinted at the beginning, we've had a fair amount of pushback from volunteers and donors who really want to do the hands-on medical care and take blood pressures and practice. We're holding the line against what we would call the traditionalists in medical mission models, and hoping to develop a model that is much more progressive, more in alignment with accompanying those that we're trying to care for and care with, as well as to be able to distribute that model and disseminate it to others that are involved in these activities. So thank you very much. I've really appreciated the chance to present. I'll look forward to the questions and answers, and also hearing the thoughts of the other members of this particular panel and others over the weekend. Thank you.
Thank you, Susan Nedza, for that wonderful presentation, especially for the art of accompaniment in the work you are doing in Honduras. Thank you very much. And so now I'm delighted to introduce our second presenter. And our second presenter is Soojung Kim. Soojung Kim, who from 2012 has been the assistant professor for the Department of Medical Humanities and Social Science at the Catholic University of Korea College of Humanities. She is a member of the following organization: the Roman Catholic Archdiocese of South Korea, Committee for Life, the Korean National Institute for Bioethics Policy, Center for Institutional Review Board. She also sits on the editorial committee of several academic journals: Personalism, Bioethics, the Korean Journal of Ethics, and the Korean Journal of Medical Ethics, where she has published extensively on these topics. Dr. Kim holds an MA in philosophy from Ewha University in Southern Korea and received her PhD in the same field from the Catholic University of America in Washington, D.C. In addition, she has translated or co-translated the following books into Korean, that is, The Domestic Principles and Bioethics, Medical Care at the End of Life, A Catholic Perspective and Principles in Medical Ethics. So her topic of presentation is the history and mission of the Catholic Medical Center in Korea. So as I said earlier, Soojung Kim was not able to join today. However, we will listen to the video presentation of her work. So welcome.
Hello, everyone. I wish I can be present at the conference in person, but due to COVID-19 pandemic, this is the best option I can choose. Let me read my manuscript. The history and mission of Catholic Medical Center. History of Catholic Medical Center in Korea. Since the Catholic was introduced in Korea in 1784, medical activities were limited to the personal level as a practice of loving neighbors. Medical missionary activities at the church level began in the 1850s when Father Maestro, a member of the Paris Foreign Mission Society, supported by the Congregation of the Holy Spirit, our child relief organization in France, began to care for the hungry and raise orphans in Korea in 1859. He also carried out medical activities, including the installation of resident stations, the medical activities of the Catholic Church, which had been supported due to persecution for 20 years, resumed as the freedom of mission was allowed in 1886 after the Treaty of Korea-France. It started with charity pharmacies in orphanage and nursing homes and then expanded to the charity clinic. When the Korean Catholic Diocesan celebrated its 100th anniversary in 1931, the Catholic Diocesan Youth Union in the capital reached the consensus that the first and most appropriate project was to establish a medical institution. The opening of St. Mary's Hospital in 1936, after 5 years of preparation, was a historical moment for the medical missionary work for the Catholic Church in Korea. St. Mary's Hospital began with 15 medical professionals and 24 hospital beds. However, 80 years later, it became the Catholic Medical Center, which has 9 affiliated institutions, including Medical College and Nursing College. It is currently one of the largest medical centers in terms of scale and income in Korea. The achievement of St. Mary's Hospital, which has been in place for over 80 years, can be explored in 4 aspects: contribution to national medical care, qualitative medical care and innovative medical research, social works and charity activities, and pastoral care and hospice. CMC currently has 5,800 beds and 13,000 staff members. It trains about 10% of the national practitioners every year and has produced about 8,000 interns and 7,000 residents. CMC takes care of 6.4 million outpatient, 1.9 million inpatient annually, which amount to 5% of the Korean population. St. Mary's Hospital has always paid attention to the marginalized and underprivileged medical fields in society from the beginning. The Catholic Industrial Medical Center was established in 1962 as a subsidiary of the College of Medicine of the Catholic University of Korea. It was created to meet the growing needs of industry, which was suffering from work-related disease and injuries, and required a way to enlighten the public on this subject. The Hansen Disease Research Center in St. Mary's Hospital was founded in 1961 with the financial help of Father Joseph Sweeney of Maryknoll of America and the Catholic Leprosy Service of the Korean Catholic Church. It has been dedicated to the treatment of the disease and the identification of its underlying causes. Furthermore, it has focused on protecting the human rights of people who suffer from Hansen disease against social discrimination and stereotyping due to the misunderstanding. St. Mary's Hospital has been recorded as Korea's first hospital in the following: corneal transplantation, kidney transplantation, pediatric cerebrovascular anatomosis, inguinal microvascular surgery, leukemia patient allogeneic bone marrow transplantation, liver transplantation, hematopoietic stem cell transplantation, small intestine transplantation. Hematopoietic stem cell transplantation was performed in more than 300 cases per year, and 600 liver transplant and 2,000 kidney transplant were provided in 2011. St. Mary's Hospital has promoted qualitative medical care through innovative medical research. Scientific development with specialization and compartmentalization of medicine has isolated patients from their body and illness experience. Modern medicine tends to regard patients as a means of medical technology rather than the subject of medical act. Patients alienated from personal encounters with medical professionals and their holistic care no longer deal with anxiety and suffering from their illness. Furthermore, the commercialization and conglomeration of hospitals discourage Catholic medical institutions from maintaining their identity in the healing community. The core identity of healing community of CMC is maintained due to pastoral care and hospice care in this difficult situation. Pastoral care deals with spiritual needs of people who suffer from mental and physical illness, regardless of their religion. It provides liturgical activities such as Mass, Sacrament, and other blessings through which people can meet Healer Christ. In addition, faith education and counseling for the staff as part of pastoral work lead to the sanctification and evangelization of the staffs. Hospice takes care of terminally ill patients and their families through physical, emotional, social, and spiritual care, allows them to enjoy the last moment of their lives in peace while maintaining their human dignity. It also helps families overcome their pain and sorrow after bereavement. Challenges and agendas. The first challenge was criticism and reflection on whether the enlargement of the church hospital was necessary. As the hospital expanded and became more commercialized, It resulted in a decrease in religious people's involvement in the management, and personal encounters with the patient seemed to be disregarded. Since the 1980s, CMC has begun to ponder whether the church really needs to run a big and extravagant hospital, or if instead it needs to concentrate on caring for the underprivileged. Furthermore, the government regards medical literacy as one of the nation's new growth engines and has set up a so-called Advancement of Medical Service Plan. The project recognizes healthcare as a commodity and utilizes it as an investment opportunity. In particular, the opening of the medical market due to the emergence of the market economy and neoliberalism and the advent of infinite competition let Catholicism gradually fade from the medical business and boost unintended competition for survival. To rediscover the mission of CMC as a church medical institution, it was necessary to overcome both internal conflicts and external challenges. The Ideology Setting Committee was launched to address these concerns in 1985, and the ideology of CMC was proclaimed with approval of Cardinal Kim Soo-won the following year. The ideology of CMC as a healing community needs to be implemented in care, research, education, and training, and management. Furthermore, it was necessary for all members of CMC to share and confirm its mission as a healing community through education and collaborative practice. CMC developed an educational program through which workers in CMC share their core values and appreciate working in the Catholic institution. Window of Communication is a project that aims to acknowledge the unique values of CMC and implement its mission as truly healing communities through interprofessional education and collaboration. It was agreed that the mission and vision of the institution should be confirmed among employees in a reasonable and timely manner. The task force team was composed of 15 medical professionals, 25 medical staffs, and 12 priests and religious leaders from 8 institutions in CMC. Its aim was to develop educational models and train in-house instructors. The core values of CMC's mission and goals are represented as follows: respect for life, medical mission, patient-first holistic treatment, nurturing mature and competent professionals, creative research based on Catholic ethics, and mutual trust and ethical management. Window of Communication, an educational program through interprofessional collaboration, was conducted 87 times on May 27, 2016 for employees who have worked for 5 years since 2012. CMC also has awards best teams that implement CMC's mission every year, so the people in CMC confirm their core values as a healing community and are proud of working in CMC. Ethical treatment and research. Ethical issues arise from the application of some advanced medical technologies to medicine. The church tradition has continually reminded us that the ultimate purpose of Catholic medical activity is the service for human life, and has firmly rejected any attempt to resist it. Science and technology exist only for human beings, and every new medical discovery or marvelous technology reveals its true value in its service to humans. The prevalence of anti-life activities such as suicide, abortion, euthanasia, and environmental destruction threatens the dignity and sanctity of human life. In addition, biomedical engineering such as embryo stem cell research and genetic engineering regard human life as a commodity and object of manipulation. The Seoul Archdiocese of Korean Catholic endeavored to make a turning point from disregarding human life, including embryonic stem cell research, live cloning, and abortion in early 2000, established a committee for life under the governance of Nicholas Cardinal Jung in order to protect human life and promote the fundamental values of Catholic Church on October 5, 2005. The Committee for Life has supported life promotion activities and medical research. In particular, the Committee for Life founded the Catholic Institute of Cell Therapy in order to shun any research or treatment that include the destruction of human embryos and promotes all research and treatment that protect the dignity of human life. Human life is a gift of God's love and should be respected at every level. The lives of those who are weakest and least able to protect themselves need greater acceptance, love, and care. To prevent any attempt to disregard and destroy further lives, CMC is actively carrying out, along with strengthening the education of biomedical ethics, various social activities and research, such as adult stem cell research and treatment, natural pregnancy methods, incurable disease treatment, and research, hospice, blood donation, bone marrow donation, suicide prevention, etc. To disseminate the teachings of Catholic Church on human life and promotes life culture, the Catholic Institute of Bioethics and the Nicholas Cardinal Jung Great School for Life were established at the Catholic University of Korea in 2007. Both aim to provide interdisciplinary education related to human life, arrange the opportunity to reflect on the influences of biomedical technology, and foster workers who will promote life culture by exploring the mystery of life. To address the ethical issues and concerns of biomedicine, CMC has published various Catholic ethical guidelines, including medical ethics guidelines, and Catholic clinical medical ethics guidebook. In addition, the Medical Ethics Committee was established to ensure that all medical personnel in the institution comply and supervise those who do not, in order to lead ethical research and assure the protection of research subjects. St. Mary's Hospital acquired AHAP certification for international clinical research jointly by 8 hospitals under CMC in 2010. Care for the underprivileged and marginalized. With the introduction of the National Health Insurance System, today basic medical services for the whole nation are theoretically possible. How can we maintain and function traditional charity care as church medical institutions? This will be necessary for the Catholic medical institution to maintain its identity in the periods when government policies, laws, and medical systems are applied uniformly to all medical institutions. By the 1970s, most Catholic medical institutions were largely focused on charitable work for the poor. Since the mid-1970s, the improvement of the national economy and the government active participation in healthcare have changed the charitable nature of Catholic medicine. However, regardless of the prosperity of the Korean economy, it is inevitable that underprivileged are excluded from access to health care. Patients who fail to pay for expensive medical care are more common than ever, and from the church medical institution's point of view, the financial burden for some charity care is greater than ever. In Korea, hospital-based home care, which was created for the early discharge of patients to reduce medical insurance deficit and increase hospital utilization in tertiary hospitals, did not benefit the poor in the community, CMC has operated a family nursing team in which hospitals and churches connect with one another to reach out to the poor and sick in the church community since 1996. Home visiting nurses are caring for elderly people living alone or chronically ill patients suffering from long-term illness. Since health means to restore physical, psychological, and spiritual integrity, pastoral care should be strengthened to patients as well as healthcare workers. Mission and task of the New Age. If medical missionaries of Korea's Catholic Church in the 1950s or 1960s had a strong philanthropic proposal, it might be said that today it has the evangelical answer to the dehumanization and secularization of modern medicine. Because all human beings are created in the likeness of God, we have the dignity to receive maximum respect. Medical care is an important and necessary work to protect human dignity and sustain the full growth of humanity. The Church's medical care should eventually be inseparably linked to all problems that harm people's health and life in the community, including political, social, and economic problems. The goal of Catholic medical missionary work, which has a long tradition, is not just to cure patient illness, rather it is to restore humanity to the fullness by healing physical pain, disease, and achieve the development of total human resources. Therefore, the missionary work of the Catholic Church should go beyond disease treatment and expand its activities by contributing to a life culture that respects human life, protects the sanctity of all people, and promotes humanity. In the future, medical institutions in the Catholic Church should also engage in activities that are conducive to the international community, focusing on the following activities. First, it is necessary to provide data and evidence on the contribution of Catholic Church medical institutions to the achievement of the UN Sustainable Development Goals. Second, it is necessary to empower community-based church medical institutions to strengthen their impact on healthcare indicators. Third, monitoring and cooperation activities should be strengthened so that budget of government agencies can be properly used to achieve sustainable development. Finally, the activities of Catholic Church medical institutions should be carried out in close connection with achievements of the common good as well as sustainable development goals. The medical missionary work of the Catholic Church is to embody the Spirit of Christ, the healer, and proclaim God's love in the gospel. As Jesus said, heal the sick and raise the dead, cleanse the lepers, and cast out the demons. Caring for those who are sick and suffering from disease is an important duty of the Catholic Church. In closing, I would like to reflect on the words of comfort and encouragement that Pope Benedict XVI gave to healthcare workers. To all those who work in the field of health, and to the families who see in their relatives the suffering face of the Lord Jesus, I renew my thanks and that of the Church, because in their professional expertise and in silence, often without even mentioning the name of Christ, they manifest Him in a concrete way. Thank you very much.
Okay, we want to thank Kim for that wonderful presentation on her topic, the history and mission of the Catholic medical care in Korea. And now we'll move on to our third presenter of our session today. And I take this opportunity to introduce our third presenter, who is Samuel Orach. And Samuel Orach, for the first 15 years, has served as an executive secretary of the Uganda Catholic Medical Bureau, the health department of Uganda Episcopal Conference, which comprises of 296 health facilities, including 33 hospitals around the country. His main areas of interest are health system, especially corporate governance in the health sector, and public-private partnership for health as a vehicle to service delivery and strengthening health systems. He has over 31 years of management and leadership experience in public health and has worked both for the government and the church. Samuel is a graduate of Makerere University Medical School in Kampala, Uganda, and holds a Master in Primary Healthcare Management from Istituto Superiore di Santina in Rome. He was also Herbert Humphrey Fellow in 2000 at Emory University in Atlanta. So both within Uganda and internationally, Dr. Orach has served on a number of governing and advisory boards, including 12 years on Health Policy Advisory Committee of the Ministry of Health in Uganda. He is also a member of Board of Directors of Uganda National Medical Sector, STOS, Board of Emmaus Foundation Trust, a faith-based Italian organization, and also a member of International Confederation of Catholic Healthcare Association. And in March 2012, Pope Benedict XVI appointed him as a consultant stroke advisor to the Pontifical Council for Health Pastoral Care. So we will listen to the video presentation of our third presenter prayed for us in a short while. And he will join us in Q&A since he is already here with us in the background. So Karen.
I will be talking to you on the theme Rise Up and Walk and looking at health systems in the Global South, and in particularly the work of the Catholic healthcare in this Global South. And we'll be asking the question, does the giant matter? And in this case, the giant is the Catholic Church. In the first case, is the Catholic Church a giant? I think that's our major question. So to discuss all these, the presentation will have an introduction, an understanding of the theme and sub-theme, and the Global South, and a brief look at the health systems in the Global South, but particularly in Africa. We'll look at the contribution of the faith-based health services in the above context of health systems. And then also particularly focus on what the Catholic Church is doing. Uganda will be a typical example. We'll make a conclusion and a call to the Catholic Church. Rise Up and Walk comes from the Bible in various texts, in the Acts of the Apostles, in Matthew, in Mark, and in John. And all of them basically relate to Jesus making the crippled or the paralyzed rise up on their feet and walk. Therefore, it's a mobilization to the Catholic Church that is crippled by various challenges to rise up above these challenges and shine in the health sector. It's a mobilization to pull together, hold hands tightly and rise. It also means pulling up together, being linked to the universal health coverage slogan of leave no one behind. Definitely, there is an invisible giant in the house that could do better. The global North and South divide is mainly on economic basis, and the Global South basically denotes mainly the low-income countries. The Oceania is part of this Global South, but we know that the Australia that belongs or is part of the Oceania actually belongs to the Global North because of its economic status. Africa, and especially Sub-Saharan Africa, scores poorly on many global rankings of health and health systems indicators. Sub-Saharan Africa is characterized by low socioeconomic index, which impacts negatively on the burden of disease and health systems. Africa has most of the countries with extreme levels of poverty, and only 5 countries on the continent have less than 5% of population living in abject poverty. Most of the countries in Africa have levels well over 25%. The high burden of disease is seen in Sub-Saharan Africa is largely attributed to by infectious diseases that are otherwise preventable. But we also see a transition taking place in the region, leading to increasing prevalence of non-communicable diseases. So let's look at the system. A health system, has no definite uniform definition. But generally, a health system comprises of organizations, institutions, resources, including people, health service delivery structures, which together produce actions whose primary purpose is to improve health. At every institutional level, health systems are arranged along the WHO's 6 building blocks of leadership, governance and management, human resources, finance, health financing, information and informatics, medicines and medical technologies, and service delivery structures, including the referrals. And any health system where you get these 6 building blocks, the building blocks are actually interlinked. They support one another, they rely on one another. In general, health systems in the global south are weak. Weak not because the health experts do not know what to do, but mainly because of underfunding. And underfunding basically because health does not take the top political priority in the countries. And once you have underfunding, it affects all the other building blocks. Consequently, you have a vulnerable health system that provides inequitable health services and is overburdened by preventable diseases and can easily be manipulated. So let's look at health financing as the key building block for all these. Most African countries spend less than $100 per capita per year on health. And we see that in low and middle income countries, the expenditures are really low. And you look at the low income countries being the worst, with the low government share of the current health expenditure. This gives us a similar picture with very low funding to health in proportion to the total government expenditure. Government expenditure may be rising, but health receives proportionally less in both low and lower middle income countries. Consequently, there's high out-of-pocket expenditure in low income countries. So you have a situation where poor countries are the ones that have the highest out-of-pocket expenditure on health. Uganda is a typical example. You see the proportionally government expenditure on current health expenditure reducing and out-of-pocket increasing, and yet Uganda is one of those poor countries. At the same time, proportionally, donor funding or external funding is increasing because also government funding is reducing. But wait a minute. We should not get the impression that increased donor funding means actually increased funding to health in general. A huge fraction of the increasing or rising donor funding is actually for global health initiatives on HIV, TB, and malaria, leaving many other common health conditions to the little government and out-of-pocket funding. You see that from year 2010, 2011 to 2019, 2020, the proportion of government expenditure out of the total, for health out of the total government expenditure is actually reducing. In 2010, 2011, it was 8.9% of total government expenditure. And in 2019, 2020, it was only 7.2% of the total government expenditure being for health. This gives us the same picture showing that other sectors, non-health sectors, actually receive more of the increasing government expenditures, while health remains low. Human resource is another very important building block for health systems. In 2006, the Americas together had 14% of the world population. Sub-Saharan Africa had 11% of the world population. The Americas had 10% of the global burden of disease, while Sub-Saharan Africa had 25% of the global burden of disease. But the Americas had 42% of the world health workforce to deal with 10% of the global burden of disease. Meanwhile, the Sub-Saharan region in Africa had only 3% of the global workforce, health workforce, to deal with 25% of the global burden of disease. At the same time, the Americas spent over 50% of the global health expenditure, while Sub-Saharan Africa had only 1% of the global health expenditure. So you can see the disparity in health financing, leading also to great disparity in human resource. That picture to date has not changed much. So in this context, where are the faith-based organizations or the religious bodies, including the Catholic Church? One would imagine that in this constrained situation, the church would not stick in there, would not continue with health services. But for the church, including the Catholic Church, it's not a matter of choice, but rather a scriptural demand and a moment for evangelization. Jesus combined the preaching of the word with practical healing of the diseases and sicknesses. In most African countries, in fact, faith-based healthcare started as early as the 19th century, and in many cases provided the foundation for eventual national health systems. A study of the African Religious Health Assets Program of the University of Cape Town in 2006 reported that faith-based organizations made contributions to the national outputs ranging from 30 to 70%. Of course, this depends on which indicators one is looking at. So who is the giant? Is the Catholic Church a giant? Is the health system of the Catholic Church a giant, or both? But first, where are these Catholics we're talking about? In 2017, the baptized Catholics formed 17.8%, we can say 18% of all of the whole global population. And this 18% population were mainly in the Americas, 48%, followed by Europe and Africa. The Catholic population is growing in Africa, in both size and its influence. One key thing to note is that over 100 years, from 1910 to 2010, the population of Africa grew from being 1% of the population of Catholics in Africa grew from being 1% of the global Catholic population to 16% in the sub-Saharan region. But does that growth matter? Does it make the Catholic Church a giant? Yes, but only if we make it visible, because at the moment, it seems not to be very visible. Worldwide, the Catholic Church remains the largest non-governmental provider of health services. And 65% of these are reported to be in the developing countries, that's the global south. And a significant fraction of those are in Africa. But it's not easy to get continent-wide data about them, because some Episcopal conferences do not readily share data or information on the services that provide, health services they're providing. So where is the evidence? The evidence is actually there, but making it talk for many religious bodies is a challenge. Therefore, the visible remains invisible in the scientific sense. Many African national governments recognize the important role of the faith-based bodies in health, and a number of them have formal partnerships with faith-based bodies operating under one government policy. with the Minister of Health as the overall person in charge. For example, in Uganda, in Ghana, but also between government and Christian health associations in Zambia, Malawi, Tanzania, and Kenya. Let's look briefly at two examples, Ghana in the West and Uganda in the East. In Ghana, in 2018, the Catholics made 13% of the national population. But these 13% of Catholics owned only 2% of the hospitals in the country. But with only 2.2% of the hospitals in the country, they had 20.7% of the hospital beds in Ghana. And look lower down, you have 10.7% of the health workforce in the country and 20% of admissions, inpatient care, and 29%, about 30% of minor operations, and 23% of major operations. But if you compare this Catholic health service against all faith-based organizations in Ghana together, then you see even a bigger contribution, because then the 39 Catholic hospitals make 41% of all faith-based hospitals under what is called the CHAG, Christian Health Association of Ghana, and 41% of hospital bed capacities. And you go down, you see 78.7% of minor operations and 63.4% of major operations. So within faith-based providers, the Catholic Church in Ghana is a giant. In Uganda, we have what we call the private not-for-profit. About 75% of these are faith-based, others are not faith-based. The Catholic health facilities, if we look at only hospitals, the Catholic hospitals make 21% of all hospitals in Uganda, and 59% of the faith-based not-for-profit. But if you put all faith-based together, that's 52% of the all private not-for-profit. Now, it means again in Uganda, the Catholic Church is a giant among the faith-based health providers, because it's having 52% of the hospitals, 57% of the health center 4s, those are mini hospitals, 86% of the health center 3s, and 17% of health center 2 is a giant. The Catholic Church in Uganda is 39% of the population, according to the last census. Similarly, compared to the proportion of health facilities we have seen here, also in terms of service provision, it has 68% of the bed capacities among the faith-based private not-for-profit, 58% of the total outpatient, new outpatients coming. And when you go down, you see 63% of the antiretroviral therapy patients and TB patients currently on TB, 84% are in the Catholic health facilities. And if you put all the private not-for-profit, the faith-based and non-faith-based, you still see a big fraction of bed capacity, outpatients, total admissions, major surgeries, are still being in the Catholic health facilities. How are they financed? You can see that the major source of funding to these Catholic health facilities is out of pocket, just like we have seen in the global picture that the low-income countries, which are poor, are having the greatest out of pocket. 54.8% in 2019-20 came from out of pocket, and 24% from other sources and external donation. The government support has been reducing in proportion. It was now 6.1 in 2019-2020. And you see, therefore, reliance on a poor population for out-of-pocket. So the challenges these Catholic facilities face are, first of all, financial, because they're serving a poor population. And there's an understanding that because they're not for profit, they are considered to be more or less free. And yet there is no free lunch. There's a perception that faith-based services are a charity and legacy of the missionary works that used to provide free health services. And there's a perception that health facilities, Catholic health facilities, receive funding from the Vatican, and yet they don't. We have high turnover of human resources, and also in many of faith-based health facilities, not only Catholics, corporate governance is still an important issue. There is a failure to create awareness about the services, hence the invisibility of the visible. Because largely creating awareness about services is interpreted to mean advertisement. And it is basically an overextending of the meaning of certain biblical verses. You can see when Jesus healed the leper and he said, he sternly ordered him, saying, mind you, say nothing to anyone, but go and show yourself to the priest and make the offering for your healing prescribed by Moses as evidence of your recovery. Again, when he healed the little girl and her parents were astonished, but he ordered them not to tell anyone. So these are misinterpreted that we should not be talking about the services that we are providing. But there is also the problem of poor advocacy skills and inability to use data for visibility, and that very much deserved advocacy. There's mutual suspicion between church and state, because the church suspects that the government is sometimes interfering in what it is doing, and then the state thinks the church is hiding resources that it is getting from Catholic donors in the global north, including the Vatican. And there's competition with the government, where particularly we are having out-of-pocket, we are relying on out-of-pocket, and government services are perceived to be free, and yet there's a lot of under-the-table charging of patients as well. And there's a huge brain drain because of the better salaries in government. And there's a technological challenge where, because of the low financing, we end up having obsolescence of technology due to lack of these resources, hence failure to digitalize our systems. And this affects mainly the rural facilities more. There's a reluctance to partner with bodies that conflict with Catholic teachings. And that is not should not be a very big issue, but it leads to missing of resources to strengthen systems, because some of the partners who would give us systems attach certain other conditions to them. Some donors are slow at working with health departments that are not corporate or not entities separate from the mother church. They want to see the health department being a separate corporate body by itself. The increasing funding for HIV occurs while we see that funds for general health system and health services are reducing. And these are challenges that affect both government and the church. So these threaten the sustainability of Catholic health systems and health services. So in conclusion, health systems in the global south are generally weak. They are also majorly due to, they're weak majorly due to underfunding and lower political prioritization, operating amidst weak national economies, and the faith-based who provide service to complement government also face similar challenges, particularly of health financing. The Catholic Church is growing in size and proportion, particularly in Africa. In some countries, it's providing the largest of the non-state health services, hence being a giant, especially among the faith-based organizations. But little is done to make the giant visible or to attract more partnerships and support. It can surely do more and stand tall as a very important player in the health sector with relatively stronger health systems. Finally, I want to make this brief call to the Catholic Church. that the church should turn the growing science in the global south, especially in Africa, into an opportunity to do more healing ministry, bring innovations in the sort of services provides, not only in healthcare, but also in the communities. The giant must rise up to be seen and appreciated by strategically strengthening its systems and making better use of the massive data it has. It must be seen as the #1 and preferred partner in health and be able to influence national policies and even more. We as a church need to explore alternative health financing mechanisms. For example, the national health insurance or the community health financing, various community health financing mechanisms that are available. If we alleviate the health financing challenges, the rest of the health systems will become stronger. I want to thank you very much for listening to me, and let us rise up together and walk. Thank you.
So thank you, Dr. Sam, for that wonderful presentation. And if I would ask Sam also to join us through the video. Okay, thank you, Dr. Sam. So here we are joined by two medical doctors. We are privileged to have you on this panel. And so I will go direct to the questions that have come from our panelists, and just a minute. So the first question read, have you heard of mission without conquest, an alternative missionary practice? So I'll begin with Dr. Susan. Maybe if you'd like to say something, and then after that, maybe Sam too, if you'd like to say something about mission without conquest. Welcome.
Thank you for the question. I'm not familiar with that particular effort, but we'll look it up after the meeting. I think there have been so many waves of evangelization in Central and South America that we see multiple different models. My organization isn't the first one that stumbled on the fact that what we were doing isn't correct and probably isn't what's best for the community. The Mennonites, as you mentioned, have been in this area for a very long time. And my experience with the Mennonite community in Honduras has been one of they take a very integrated look at health with some of the other services that they do. And there are groups that are associated with Partners in Health, I know in Mexico, and others that have taken a more holistic view about their role. And I think that's also one of the more challenging things is that we as those that are involved in the Catholic diaspora there, that we have not had the opportunity or really haven't had the infrastructure to build the bridges to learn from other people. Like the Mennonites that are just mentioned in the chat, in the questions in Argentina. I did do some research before the Nigeria conference looking at other models in mainly South America. There aren't as many of these medical mission trips, which is my specific focus, but I'm sure they exist. And I thank you for bringing that particular group to my attention.
Thank you, Susan. Maybe Dr. Sam, if you'd like to say something on mission without conquest.
Thank you very much, sister. I think I'm trying to reflect on the time I have worked in the hospital as a practicing doctor, but also as a district health officer at one point, and now handling policies over these matters. I think there's been a lot of transition over the years, and we have seen basically colleagues who come from outside Africa joining us as colleagues and working together. So I think if I get a team of surgeons, a team of physicians, a team of pediatricians, and we come and work together on something, we share knowledge. They learn from us and we learn from them. And that's what we see is basically really now happening. Many, many years ago, that sort of medical mission used to happen. But I think now I would say it's very little. From the time I became the person coordinating the health services of the Catholic Church, I have seen some of such requests of people coming. And I think I have always responded that please send for us colleagues with whom we will share knowledge and experiences. Don't send for us people who are going to do sort of tourism.
Yeah, I would add that the models in hospitals are definitely ones that have been more productive. There's a Catholic hospital near where we are in Honduras that has a very similar model where they bring, people specific expertise in who then, work with the physicians there. Sometimes they're just as skilled. They may bring a new technique, but in fact, they learn sometimes, a different way to do things. And so that model is one that when people call us that have those skills, anesthesiologists like my husband or surgeons, we will send those to those programs just for the reason you mentioned. And that has been, but again, we're an outside group referring people to the Catholic Church. There's no specific, as you said, rising up. That Catholic hospital has not risen up to seek those people through us. They're actually working with the Lutheran Foundation.
Okay, thank you, our presenters. And now I want to come back to you, Susan. There's a question that was addressed to you by William. I would request you that you can read that to the public and maybe respond to it.
Let me pull it up here. Let me get it here. Sorry, to my answer box. So Bill asked specifically about a short-term missions in Latin America and something called Yankee Go Home that's associated with Ivan Illich. And it's about how, there's volunteer shock when individuals go into Latin America. Now, these are North American volunteers. But at the same time, the villagers have no way to prepare for the culture shock of meeting these most affluent volunteers. And how do we prepare people in the villages for the shock of meeting you in your group? So we are blessed by having an organization on the ground there. Before COVID, we had 125 Hondurans working with us, or we work with them, I should say. That number has changed because of COVID, but they are charged with the relationship both with the diocese and with the parish priests, the sisters, and the laity that work in the parishes. We don't limit our services to Catholics, but they do serve when there's any type of interaction, health or other, to help, grease the wheels isn't the right term, but help make it better. The other point is we've been doing this for a number of years. When I came in 2015, and there were teams that kept going back to the same town every year. So they developed personal relationships, but they kept doing the same thing without measuring it and finding out there was any impact. So our biggest challenge has been in getting the villages in the area to understand why we're not doing that anymore. Why are we not coming and providing, Western medications? The people wanted the medications we were passing out. And we said, because it doesn't help. And so we had to do a lot of education about why we've pulled back from that model and to move towards the clean water model, about, trying to help their children with, their intestinal parasites through water filtration systems, as opposed to, once a year administration of anti-helminthics. And so that has been a challenge as well. And I appreciate the question from Bill, because you've got to, especially if you're trying to change these things, everyone involved has to understand why and how, because it really did disrupt some of the, first of all, the donors on our side, but also there was unhappiness in the communities as well because of our change in our model.
Thank you, Susan. So I see there's a question directed to you, Dr. Sam. And the question is there health insurance source of help or out-of-pocket expense in Uganda or the rest of Africa? Dr. Sam.
Well, first of all, I start from the unfortunate fact that we have spent over 10 years talking about introducing the national health insurance in Uganda. And up to now, we haven't. But we have private commercial health insurance, which the majority of the Ugandans can't afford. The Catholic Church, let me say the churches, pioneered the introduction of community health insurance many years ago, over 20 years ago in Uganda. But you know, when you're talking of community health insurance, where the subscribers are the very poor people, there's only just a little that they can finance through that. The premium will be too high for them when you want to increase the package and the quality of service that you need to procure for them. So it becomes quite a challenge. We have had the debate about the national insurance going to the highest level. I was in a meeting with the president and other people where there was quite a lot of discussion, and the head of state, the president, definitely was in support of us introducing the national insurance, but he was very concerned that the design of the national health insurance was not taking into account the plight of the poor people. So he has referred the whole bill back to be, to be looked at, so that there's adequate provision to ensure that care is still provided for the poor who cannot manage even maybe to subscribe or to pay premium to the national health insurance. So yes, the health insurance would be of help, but there are also studies across Africa that have shown that sometimes where you have health insurance working very well, it has not necessarily led to a reduction in out-of-pocket expenditures. I don't know the reason very well, but somehow, in some cases, even out-of-pocket expenditures have increased. Thank you.
Thank you, Dr. Sam. I'm sorry, I just have to keep asking both of you because you are just the two of you in the panel. A question to you, Susan. Somebody is asking, you mentioned that the part of your mission is to help people to stay home in Central America. If you are in charge of immigration policy for the US government, what would you do to address the immigration issue that is so controversial right now? To you, Susan.
We're engaged in that conversation right now because the Biden administration has put out a plan that basically speaks to going around the government, to using NGOs and others that are active to do development, integral human development in Honduras. Certainly Caritas is part of that, so is USAID. Unfortunately, there's very little connection between the alphabet soup of all the other people working in the country. If I had, I had my way and I was empress, I would suggest that the church in Honduras reach out to all of us and help us develop a model that we can take to the US government to do some of the work, because many areas like where we are in rural Honduras isn't really, it's not the worst of the worst. It hasn't had hurricanes and it hasn't had drought, and we don't have a drug problem, but that doesn't mean we don't have poverty and we don't have needs for better health care. So I think some type of activity by the church in Honduras and in the United States, in fact, would be extraordinarily helpful to help bring us into the fold for those that could potentially do more development. And I'll maybe if I might add one other thing, we are currently engaged in a 3-year commitment with Notre Dame School, University of Notre Dame School of Mendoza School of Business, looking at how we foster economic development and health system strengthening. And so I think that is another area where I think as Sam mentioned, in Africa, they're further ahead of us in many ways. And we need to be able to have more of those type of programs that not only improve health, but allow especially young men to stay home and have work in the community. Long-winded answer.
Thank you, Susan. And now a question for you, Sam. Is there an overemphasis on high-profile illnesses like HIV and AIDS? And if so, how should the overemphasis be corrected? To you, Sam.
Well, yes, I actually did mention in my presentation that of the increasing external funding, a huge fraction actually goes for the HIV/AIDS and HIV/AIDS, TB, and malaria. And data from Catholic health facilities here shows that about 10 years ago, 80% of donor fundings that facilities were getting were actually for just this HIV, TB, and malaria. Now it has reduced to about 60 to 70% of all the donor funding. So it's quite a big emphasis. Right now there's quite a big debate on how much money we are spending on coronavirus with apparently low mortality rate and so on. But the emotions are there about the huge amount of money we are spending on coronavirus. So how can we stop that? I think the first thing is that we need to focus a little bit more on prevention in general, so that we even reduce the need for clinical healthcare if we can focus more on prevention, and particularly working with the communities and not just coming to provide service for them, but working with the communities to take charge of their own health, sort of empowering the communities. So that is one thing I see. And we need to also spend, I'm not saying at the expense of direct health expenditure, but we should also spend a little bit more on other social determinants of health that will also reduce demand for healthcare, more clean waters, the nutrition and others. We need to spend a little bit more on that. But I think, in my opinion, I have shown you the graphs showing total government expenditure increasing, while actually the allocation to health is minimally increasing, almost remaining flat. The government should be seen to be increasing its own part for the current health expenditure. And if that is done, then it will probably balance the effects that we are having with external funds going more to these global health diseases. For HIV, we are now approaching epidemic control, but epidemic control does not mean epidemic elimination of the disease. So we will still continue, but we will be in a balanced situation where I think we can start moving resources a little bit more to the others, maintaining the factors that have led us into getting epidemic control. Thank you.
Thank you, Sam. And for our audience, we still have some time. So in case you have any question you'd like to engage our presenters, you are most welcome. And so a question for you, Dr. Susan. How do you think medical health mission from the north to the south could be implemented today in the face of COVID?
Actually, we've considered COVID somewhat of a blessing for us because it disrupted the old model. I mentioned we were trying to move some of our donor base away from the idea of the one-week medical missions. What it has also, at least in our experience, forced us to do was to increase our bonds with our partnership with the local healthcare system, so that we had a better understanding of the community, which meant we ended up using some of our funds to fund community testing sites for COVID, as well as have participated in augmenting the ability of the hospital to treat it. They had a very, as you can imagine, a significant shortage of oxygen. Even just oxygen was a significant problem. So we've used our role as a trusted intermediary between donors in the United States and those entities. Now, that said, we are not a relief group. We were very successful in actually raising more money for COVID relief than we would in a normal year. Because just like Sam mentioned about HIV, the donors got it, and there was a lot of people wanted to do something. So we'll see what happens next. But I think some of the other nonprofits, the Catholic nonprofits and NGOs I've been speaking with of late, have also had a similar experience of changing their mission. So I think there's an opportunity to kind of realign and think much more about accompaniment from a distance, if you will. As we're not there, and use technology to do that.
Thank you, Susan. Another question for you, Dr. Sam. How much does the Catholic healthcare in Africa empower the people, or does it come from outside and fail to empower the people? To you, Sam.
That's a very interesting question for me. Last year, I wrote some paper about working with the community, in moving towards achieving the sustainable development goals, but particularly universal health coverage. And I was looking at this issue of empowerment of the community or working with the community. But first, in this very presentation, I have mentioned the fact that people think that Catholic healthcare or faith-based healthcare should be free or is free because of the past experience with the missionaries. For me, that is a disempowerment of the mind, because then there's a wrong perception already, removing away the sense of responsibility of the people. Empowerment includes many things. Empowerment includes the ability to analyze issues and decide, making decisions, your own decisions. It also includes the capacity to, for example, finance what you want, maybe financing healthcare. It includes the ability to demand. It includes the ability to shape, just like I think Susan mentioned in their experience, that maybe they should have stopped. The people who are passing on the bridge should have stopped to ask those who are down in the river. So the ability to shape what should be provided for you. Those are some of the elements of empowerment. And for many years, not only churches, but also political leaders disempowered people, and that continues to date. Sometimes we get very conflicting messages, both from political leaders and religious leaders. At one point, the religious leaders and political leaders are mobilizing the communities to do something for them. At another point, they castigate managers of the hospitals. They would want the hospitals to provide free service. And sometimes the religious leaders can say, this is our hospital. It is a hospital of our people, our Christians. Why are you charging them? At that point, they lose the whole idea that there's no free lunch, that everything has a cost. Whatever subsidy that may be given to users must be financed by somebody from somewhere. And that's where we have done our part, first of all, as the Catholic Medical Bureau, working together. We have been taking the lead in the country, working together with the other faiths to lobby government. You will see from the graph where the Bashata was showing that at one point, our health services of the Catholic Church was financed up to beyond 10% by government. In fact, before that, it went to almost 20%. Then it kept reducing. And over very many years, it reduced to less than 3%. But in the last year, it has increased to 6.1%. And in the next year, it is going to increase more. That is the power of our lobby, working with the government to increase that. But even once we do that, we stand the risk of people thinking that everything must be financed by the government. So the focus, that's where the focus should move to mobilizing people to taking care at least of the prevention activities, personal health, you know, if we can empower people in that line. At the UCMB level, the Uganda Catholic Medical Bureau level, we have been implementing a few programs which are which are community-based. We carried out a study among refugees, South Sudan refugees in Uganda, and we wanted to see how working with the communities, the refugees themselves, and the host community around them directly, instead of working with health facilities, would increase the identification of cases, TB cases. And indeed, it worked. And even if we did not identify cases, even if we had not identified cases, they felt very much appreciated that they were involved. And that act of looking for cases, educating the communities will continue amongst them. Currently, we have another program where we are working in 5 districts. These districts in Kenya, where, sister, you are what you call counties there. We are using the same system. We are working with religious leaders, traditional leaders, community opinion leaders, village health workers, you know, all these, you know, in the communities. And in that way, they feel, you know, engaged and empowered. But the other empowerment is really about resources, community health, health financing ability. And there, I think as a church, we may not have done quite a lot, but the earlier question about community health insurance, for example, I think if we can do that, and if we could expand on that across the country, if only it were not affected by, you know, some of the poverty levels in parts of this country, that would also provide more empowerment. You know, when you talk about involvement of community, the word involvement has very different meanings depending on how you interpret it. Involvement may simply mean you go to the community, you tell them this is what we are going to provide for you. We want you to go and do this, we want you to go and do this, and they do things according to your instruction. That is what may be involvement in some cases. The true involvement, the true engagement in the community is when you engage them even at the time of identifying their needs and designing together with them the interventions, strategies, and activities. And then you work with them to mobilize the resources. Sometimes actually you may have the resources amongst them. And that's where I look at what the Religious Assets Health Program of the University of Cape Town calls, I think, asset-based approach. Look at the assets within the community. Some of the assets are human beings, the human being themselves. If I retire and I go back to my village in the rural part of Uganda, with all the knowledge I have, I will be an asset to my community. And we have a lot of such people in the community, but we go there with what we have designed and we start talking to them about it. So I must say, yes, for many years, actually, we have not empowered people enough. But now we are beginning to take that approach, both us as a health department, but even as Caritas. We are beginning to take that approach of empowering the communities.
Thank you, sir. Thank you, Sam. Now, I want to take this chance to also ask a question to the two of you, and any of you will can begin to respond to me. So my question is, how do you think we can be able to promote holistic healthcare, especially in Catholic hospitals, this is my focus of my PhD, so some insights would help. How can we promote holistic healthcare in Catholic hospitals, and also the issue of Catholic identity? How in our contemporary society, how can we still have that Catholic identity still felt in our Catholic hospitals? So any of you?
Sister, that is for me a cross-cutting question, and it's something that moves in my mind every day. I ask that question, that what is Catholic about Catholic healthcare? Is it the cross you find on the corridor, in the doctor's room and everywhere? Is it the fact that every morning before people start working, they pray together? What is it exactly? Is it because you find consecrated people like you working in that place? Or is it because you have priests who are there? For me, that is not enough to make a facility be called Catholic. It may be Catholic founded, but the service might not be actually Catholic. And the central answer is really what you have said, holistic healthcare. And we need to define what that holistic healthcare. But before we go there, there is also about the work ethics. You know, we have heard many times people in government and even development partners saying, health workers in faith-based institutions work very hard. Absenteeism is very low compared to the ones in government. But these very health workers, once they join government, you find they also start having high absenteeism rate when they join. So maybe we are coercing them to be at work, but at least there are certain rules of of engagement between us and them, and they tend to work. On the other side, also when we talk, for example, of things about HIV and so on, we tend to emphasize quite a lot about risk avoidance rather than risk reduction. And for example, the issues of condoms and so on, which unfortunately become the main thing for which people know us. They tend not to know us for the very great work we are doing, overall. They only look at that. But also, I think you will see that we try to stress quite a lot as part of the holistic care, we stress integrated care of somebody who comes to the facilities. One time I was moving with a colleague of mine, a friend, who is actually going to be a panelist in the next session. And we visited the hospital that I started many years ago for the diocese, for my diocese. I was the first doctor who went there. And as we entered, he saw many people seated on the compound of the hospital. And he asked me, why are all these people here? And I told him, these are the people taking care of the patient. He said, but what about the doctors and the nurses? I said, they're there inside. But care is not about prescription of medicines only. It is holistic. And part of the holistic is involving all these people in that care. My own dad, who eventually died last year, in 2013 would have died if I brought him to the big hospitals in Kampala, where he would have been isolated, and probably I would be visiting him once a day, only he had no relatives around him. In 2012, in 2013, he was so ill, but the presence of his wife, my mother, the presence of all the relatives coming around him, psychologically was so important for him and contributed to his recovery. But also here, we are the only institution that train in and provide clinical pastoral care, which I think Kim talked about, either Kim or Susan. I don't know whether it was Susan who talked about, but I think Kim talked about pastoral care. We train and provide clinical pastoral care. So you have a nurse, you have a doctor who is coming with the clinical expertise, but his own or her own behavior is already shaped by that training in pastoral care. And so the approach is very different. The dialogue between this person and the patient is very different compared to maybe some other institutions where the interaction is just simply technical, talking about the disease presentations, the clinical presentations, the investigations, results, and prescription. You don't get the other interactions. So we try to combine all these in our care. But I must caution here that there are no angels in Catholic hospitals or in faith-based hospitals. There are no angels. Not among the lay people, not even among the religious, not even among the consecrated. There are no angels. We still find a lot of weaknesses, but it's something that we really try to focus on in guiding the way we should be doing things in our network. Thank you.
Thank you, Sam. I say time is not on our side. I don't know, Susan, in 1 minute, would you say something as we wind up?
Sure. Let me just respond to the question you just asked. It's walking the walk and not just the talk. Certainly the example, the Catholic Hospital Association in the United States that supported the Accountable Care Act and expansion of coverage. It's the power in being together and the voice of Catholic healthcare that has made a difference in multiple areas, especially including in our, care along the border and our refugee crises. And so, that I agree with Sam. There aren't any angels in one particular place, but the voice of Catholic healthcare and Catholic hospitals in particular, Catholic hospitals are well suited to help the rest of us who are Catholics and the rest of the Catholic organizations who are working in health to improve the health of the community. So just like we're blowing the doors off the church, we have to open the doors to the hospital and look outside, as Sam said.
Thank you, Susan. And before I make my concluding remarks, I want to remind the audience that after the break chat, there will be also another session coming on the biblical and theological narrative of health and healing. That will be at 2 p.m. And so we have come to the end of our roundtable, and we are grateful to all of you who have joined us from different parts of the group, and particularly we are grateful to our three wonderful presenters of this session, Susan Nedza, and then Soojung Kim, and Samuel Orach. And to you, we say thank you very much. And in Nairobi, we would say, asanteni sana, Mungu awabariki. So thank you.
Asante pia.
Yeah.
Muchísimas gracias.